We are live. Dr. Ankita, we are live.
Just 1 second. Okay, so a very good evening, everyone. Welcome to it's my immense pleasure to welcome you all for the second annual YouSlide Award Grand Finale 2022. So in this season, we had 21 semi-finalists. Among them, top 6 were selected as a finalist. Now, this wasn't possible without the reviewers. So on behalf of the entire team, I would like to acknowledge our sincere thankfulness to all the reviewers who has helped us in publishing all the presentations on time and for giving the valuable suggestions. Now, before moving to the session itself, I'll quickly introduce the core team members, the members who were, who were working behind this whole work group of YouSlides to make this a success. So the first one, we have Dr. Nilesh Kumar, who is the founder of YouSlides itself. Now he is the joint secretary of UC, currently working as a consultant at Madhvi Netralaya. Dr. Kaushik Tripathi is a consultant retina at Kolkata. Dr. Ayushi, who is currently pursuing her oncology and oculoplasty fellowship at Ali Prasad, Hyderabad. Dr. Anupam Singh, who is a PG resident at RIO, Sitapur. Dr. Muskan, who is currently pursuing her MCH in cornea at PGI Chandigarh. Dr. Neelam, who is currently a VR fellow at HV Desai Eye Hospital in Pune. Dr. Rakhi, who is currently a consultant at Kerala. Dr. Sheikh, who is a consultant at Government Hospital Karnataka. And it's me, who is currently the editor and team lead of the YouSlides. So now, before moving, I'll request the founder of the YouSlides, Dr. Nilesh, to just quickly give a founder speech before we begin this program. Dr. Nilesh, over to you.
Thank you, Dr. Ankita. And it is my immense pleasure to be a part of the second YouSlides annual award. I'll just share my screen and I'll quickly go through the journey that we have all been in the last 3 years. So the YouSlides, the journey, it began like this. We wanted a curated keynote presentation with moderated scientific accuracy and a chance to present in a webinar. So this is the second webinar we are second webinar that we are having now. Will be more frequent in the future. And the YouSlide started on 15th August 2021. And we have a quite good number of questions that were directly or indirectly coming from the slides that are available on YouSlides. So in June DNB examination of June 2020, we had a direct question worth of 70 marks. So it was quite a surprise for us and a motivation to work further. And then we had an website where we were displaying all the YouSlides, and the new dedicated web page is coming very soon. And then this was the finale, the flyer for the last finale, and the introduction of the team member was done on the first. So before the first slide, sorry, the first finale, I was working alone, and then I had the team that Dr. Ankita introduced now. And then we had more patient education initiatives also. We had mucormycosis during the COVID time, eye donation, glaucoma, and ocular injuries, and we will be having more of these now. That we are having our own web page. And now we are 980 plus strong on Facebook, 450 on Insta, and 15 on Twitter. So a lot of following has occurred. When the last slide happened, we were around 400 on Facebook, and now it is almost touching 1,000. So great going from for the team that is taking it forward. This team has been has taken over once I got elected as joint secretary. So from the last AIOS conference, they have taken over and done a marvelous job. So welcome to today's finale, and all the best to all the participants. Thank you.
Thank you, Dr. Nilesh. Now moving forward. So let's begin the session. Well, the session is incomplete without the judges, and we have the 3 eminent judges who are the best in the country. So we have Dr. Kaushik sir. Will request you to please introduce Dr. Digvijay sir.
It is my privilege to introduce Dr. Digvijay Singh sir, who has been my mentor as well in AIIMS. He has done MD and senior residency from AIIMS New Delhi. He has published multiple peer-reviewed articles, 20 book chapters, and he has to his credit 20 awards. He has special interest in pediatric ophthalmology, strabismus, neuro-ophthalmology, and glaucoma. He is the immediate past president of Young Ophthalmology Society of India. Welcome, sir. And he is one of the persons who has in-depth knowledge in his specialty, and his talks and his training have made us what we are. Thank you, sir, for joining us. Thank you.
Thank you, Dr. Kaushik, sir. Moving on to the next judge for today, Dr. Vivek Dave, sir. Requesting Dr. Ayushi to please introduce Dr. Vivek.
Thank you, Dr. Ankita. It's my absolute honor to introduce our next judge, Dr. Vivek Dave. He's a senior vitreoretinal consultant at the Anant Bajaj Retina Institute, LV Prasad Eye Institute, Hyderabad. He's also an adjunct professor at the University of Rochester, United States of America. He's also a board member of the prestigious societies such as International Society of Ocular Trauma and Asia Pacific Ophthalmic Trauma Society. He's also involved in several ongoing clinical trials as a clinical investigator. He holds editorial positions in several peer-reviewed journals, namely Seminars in Ophthalmology, BMC Ophthalmology, Indian Journal of Ophthalmology. He has more than 123 peer-reviewed publications to his credit. He has a long list of several prestigious awards, some of which include APO Distinguished Service Award, Best Video APVRS, Nursing Law Award AIOC, Professor Nam Perumal Swamy Young Researcher Award VRSI, APAO Achievement Award, GM Pahava Best Free Paper, Ed Selvam Best E-Poster at AIOC, and Travel Grant Awards at APVRS and APAO. He is a clinician scientist with expertise in endoscopic vitreoretinal surgeries. In fact, he's one of the very few in the country and in the world as well to be doing it on a regular basis. He has proficiency in complex vitreoretinal surgeries, endophthalmitis, and ocular trauma. Welcome, Dr. Vivek.
Thank you, Dr. Ayushi. We'll move into our third judge, Dr. Anu June. Requesting Dr. Rakhi, please introduce the judge.
Thank you, Dr. Ankita. It's my pleasure to introduce none other than Dr. Anu June, who's a very vibrant and energetic personality. She's currently the Assistant Professor of Glaucoma and Squint Services at Guru Nanak Eye Center, Maulana Azad Medical College, New Delhi. She's also the Associate Editor of Delhi Journal of Ophthalmology from 2021 to present. She is the Executive Member of UC from 2019 to 2021. She has greater than 15 index peer-reviewed publications and more than 50 presentations in national, international, and state conferences. She's actively involved in various activities of UOC since 2018, and she has numerous awards in state, national, and international platforms to her credit. Welcome, Dr. Anu.
So I welcome all the three judges on behalf of Team Your Slides. So let's quickly go through the rules. The presentation should be within 5 minutes. Every extra minute will lead to deduction of the score, which will be around 5 marks. Presentation will be followed by question and answer session for 1 minute by the judges. Total marks for each presentation is 50. Audience poll will be opened at the end of the presentation at Zoom poll. The weightage of the audience vote is as follows: 50 for the first, 40 for the second, and henceforth. So the marking criteria just for the participants, it's mainly based on the understanding of the topic which is being presented, confidence of the presenter, clarity while speaking, appropriate use of the audio-visual aids, quality of the reference material, aesthetic quality of the slides, the content, the ability to answer the question of the judges, and the scientific content in impromptu answer. So hope it is clear. Let's begin the finale. Just 1 second. So yeah, we'll start with the finalists and the presenters, the stars for today. So for the national level, the top 6 finalists are here, and I request Dr. Neelam to start with the first. Dr. Neelam?
Yes, ma'am. Kindly share the screen, ma'am.
Yeah. Oh, sorry, I haven't shared. 1 second.
No.
Just 1 second. Share screen. Yeah, is it visible now?
Yes, ma'am.
Okay, just 1 second. Go behind. Yeah, so we have the top 6 finalists and let's begin.
Yes, so I welcome our first finalist, Dr. Aditi Jhunjhunwala. She is from Deoria Medical College, Uttar Pradesh, and she is going to present on topic retinopathy of prematurity. So, Dr. Aditi, you can share your slides now.
Thank you, ma'am. Good evening to everyone. I'm going to share my slides now. My slides are visible?
So
Okay.
time starts now.
Should I start?
Yeah, please.
Okay. Good evening, everyone. Today my topic is retinopathy of prematurity. Ma'am, can we stop the time? I think I am having some trouble like moving the slides.
Okay, just move it.
Just a minute, ma'am. What is happening? Ma'am, let me reshare.
Yeah, please.
Don't worry, be relaxed. So
तिवारी सर है उसमें
Okay, now it's working.
Yeah.
Should I start now? Okay, good evening, everyone again. Today I will be talking on retinopathy of prematurity. As we all know, this is a vasoproliferative retinopathy, which is the leading cause of lifelong visual impairment in children. It was first described by Terry in 1952, but the term retinopathy of prematurity was coined in 1951. Coming to the pathophysiology, it was described in 2 phases. The first phase being the hyperoxic phase, which resulted in... Sorry?
no, just mute everyone at the host.
Okay. Should I continue?
Yes, you can continue.
Okay. Okay, the first phase being the hyperoxic phase, where a delay in physiological retinal vascular development was seen, but the peripheral avascular retina continues to develop, leading to the second phase of hypoxia, where the formation of AV churns, retinal neovascularization, and abnormal vasoproliferation was seen. Some key risk factors were low birth weight, young gestation age, high and unregulated oxygen at birth, and poor postnatal growth. These are some of the suggested risk factors and genetic factors. Coming to the active disease, which was defined in ICROP guideline 2005 in 4 classification concepts: zone, stage, extent in Klockar, and presence of plus disease. This is a diagram showing different zones, where zone 1 is a imaginary circle with optic disc at the center and radius being twice the distance between the fovea and optic disc. Zone 2 is a donut-shaped area around zone 1 extending up to the nasal oral serrata, and zone 3 is the residual temporal crescent. In ICROP guideline 2021, zone 2 is further divided into posterior zone 2 and anterior zone 2, where posterior zone 2 is a region of 2 disc diameters peripheral to the zone 1 border, and it indicates a potentially more worrisome disease. One more terminology was introduced in ICROP 2021, notch, which describes an incursion by the ROP lesion of 1 to 2 Klockars into a more posterior zones than the remainder of the retinopathy. Coming to the stages, where stage 1 is the demarcation line stage. This diagram shows the demarcation line. Stage 2 being the ridge stage, it has height, width, and extension above the plane of retina. A small isolated neovascular tuft of blood vessels can...
Aditi, you're muted. Aditi, you're muted. Please unmute yourself.
Is it okay now?
Fine, please.
Okay. Stage 3 being the extraretinal fibrovascular proliferation stage, where abnormal blood vessels and fibrous tissue develops on the edge of the ridge. My slides, they stopped again.
Try again.
Coming to the stage 4, which is a partial retinal detachment stage, where 4A is the extrafoveal and 4 being the foveal retinal detachment. Stage 5 is the total retinal detachment, which is 5A is the open funnel where disc is visible, 5B is the closed funnel where disc is invisible, and 5C with anterior segment abnormalities. Plus disease is the venous dilatation and arterial tortuosity secondary to the AV shunting at the level of ridge in at least 2 quadrants of the posterior fundus. It is associated with iris vascular engorgement, pupillary rigidity, and vitreous haze. Pre-plus disease is the disease which is insufficient in severity to be diagnosed as a plus disease. Coming to the aggressive IROP, before ICROP 2021, it was known as APROP or rush disease, where rapid development without going through the typical stages of ROP was seen. Here, absence of ridge tissue and dilated tortuous vessels, which can progress rapidly to stage 5 with poor prognosis, was seen. Threshold disease was defined in cryo ROP study where equal chances of spontaneous progression and regression was seen. It was defined as more than 5 contiguous clock hours or 8 non-contiguous clock hours of stage plus 3 ROP in zone 1 or 2. Pre-threshold was defined in 80 ROP and it dictates the management. Two types, high risk and low risk. High risk undergoes peripheral retinal ablation as soon as possible, while type 2 is put on observation at short interval. Laser ablation in type 2 is done when it progresses to type 1 or threshold disease. These are some of the landmark studies in ROP. Coming to the screening, all the infants at risk should be screened. This is the AO guideline for screening, but in India we follow the RBSK guideline, where every infant with birth weight less than 200 grams, gestation age less than 34 weeks should be screened. Gestation age between 34 to 36 weeks, but the risk factors should be screened. Every infant should receive their first screening.
Last 1 minute.
4 weeks of birth. I will just jump to the treatment. Treatment is defined as cryotherapy, laser treatment, anti-VEGF, and surgery. Cryotherapy was defined in cryo ROP study. It is nowadays replaced by laser. Its indication are only in cases with media opacity, non-availability of laser, and surgeons' unfamiliarity with indirect laser. Laser ablation is still the treatment of choice and was defined in 80 ROP study. It is less invasive and less traumatic. It should be administered within 72 hours of determining its need. It should be done using indirect ophthalmoscope. Argon green and diode red laser should be used. Near confluent ablations with burns spaced 1/2 burn width from ora serrata to ridge, but sparing the ridge. It leads to irreversible and extensive destruction of the peripheral retina, which results in destruction of the visual field. Is one of the limitations of laser ablation. Coming to the anti-VEGF, which is fast becoming the treatment of choice in zone 1 diseases, BEAT ROP compared bevacizumab to laser treatment. A dose of 0.625 milligram per 0.025 ml was used, but the incidence of recurrence was too high, like 8.3%. Fluoresceint angiography is the standard for follow-up in anti-VEGF treatment. Rainbow study compared ranibizumab with laser. The 0.2 to 0.1 milligram of ranibizumab was used. Injection site should be 1.5 millimeter behind the limbus. Risk of cataract, endophthalmitis, and very late recurrence of proliferative ROP has been reported with anti-VEGF. Coming to the surgical management, done in stage 4 and 5. In stage 4A, we can do scleral buckling and lens inspiring vitrectomy. Lens inspiring vitrectomy is the treatment of choice, and it interrupts the progression from 4B to 5 and allows primary retinal detachment. Lens aspiring vitrectomy is also the treatment of choice for 4B, where it minimizes the retinal distortion and total RD. The goal here is ambulatory vision. These are my references, and thank you.
Thank you so much.
Well presented, Dr. Aditi. Thank you. Now I would like to request Dr. Digvijay sir to proceed with the questions.
Right. Thank you. And Aditi, well presented. And
Thank you so much.
all of us should be calm and relaxed. So don't worry. These things, hitches happen. These are technical issues. We also understand as judges, it is not possible to cover everything in 5 minutes. So sometimes, you have to rush through things, but still you have to pace yourself, I think. So a quick question for you is, can you tell me something about sequelae of ROP?
Yeah, so like sequelae of ROP, it goes like different stages. Like there's first straightening of the temporal vessels, and then dragging of the macula, fovea, and then retrolental fab, and then it will lead to retinal detachment.
Yeah, what can it result in basically? Do you think you can have squint, you can have myopia, you can have eccentric fixation? What all?
So like myopia, squint, so there's a long list of sequelae, and RD, it can lead to RD and so decrease in the peripheral, visual field.
Sure. Okay.
Okay. I would like to request Dr. Vivek sir to proceed with the questions.
Yeah, thank you. I'll also ask one question. Well presented, Aditi, but it's a very huge topic that has been taken on a mandate of 5 minutes. So let me put a very open-ended question to you. I am, say, a naive person in the audience, right? 5 minutes, it was a rapid fire presentation. Can you give me 5 objective take-home points that I take out of this class or out of this presentation? 5 points, 5 best points out of your presentation.
So 5 best points. So first of all, sir, the prematurity and use of oxygen, the role of prematurity and use of oxygen in development of ROP. So, sir, when a premature baby is born, the golden hour, we put a lot of oxygen and then we take it off. So, my first point will be, sir, that we should give a continuous neonatal care to the child. We should not vary the oxygen level and the care of neonatal care. The second is my second point will be the diagnosis of ROP. It should be like as early as possible. Initially, we used to believe that until the 4 weeks after birth, the screening should be done only when the baby is 4 weeks. But now the guideline is as soon as possible. Sorry, I mean to say that before 4 weeks, the infant should get his or her first screening. So my third point will be in the treatment, because a lot of debate is currently going on between the laser treatment and anti-VEGF treatment. And some people preferring anti-VEGF treatment over laser treatment, so different zones and different stages. Since the anti-VEGF gives us a benefit of having vascularization, peripheral vascularization. So, sir, depending on zone and sorry, sir, I'm confused what I'm saying.
Right. No problem. See, my only point was when you have 5 minutes, all right, and such a huge topic, right at the end, you may have gone through the whole topic. Just take it as a feedback. Right at the end, you should have few objective points for the audience to take home, right? So
Sure.
this is just for any future endeavors like this, if you are preparing for. After everything, just summarize. Different people might have grasped different things out of your presentation because it was basically attempting to cover the entire ROP in 5 minutes. It is humanly not possible. Even before I could read through what was there on your slide, you were into the next slide, right? So at the end, if you have some summary in your mind, which you can sort of, put across to the audience, at least the audience takes home those points. And when I asked you 5 objective points, right? So in future, anyone asks you something like this on the podium, what should come out of your mouth are 5 sentences without explanation, right? Absolute objective points. So go back and try to see if you can, summarize your presentation into 4-5 points. It will be a good mental exercise for you, and it will help you maybe teach your colleagues or your juniors with respect to the message that is there in your presentation. Right. Otherwise, a very holistic and very nice presentation. Thank you.
Thank you so much. I will keep that.
Thank you, sir. Thank you, Dr. Judges, please score the presentation. In the meanwhile, I would like to welcome a very special guest. Pratibha Kant sir is here, who is currently a Vice President of UC. Welcome, sir.
Thank you so much, Ashura. Very nice presentations, by the way. Please go ahead.
Yeah, fine, sir. Thank you, sir. So we'll move ahead with the next presentation.
So do we take a few seconds to just score, or we do it on the go as the second presenter starts off? If you can have just 30 seconds, maybe we can score off right now.
Sure.
Just a moment.
Yeah, please. So in the meanwhile, our next presenter, Dr. Aishwarya, please be ready.
Yes, ma'am.
One second. I'll just share the slide for you.
So we have our next finalist, Dr. Aishwarya Rathod, who is from RP Center AIIMS, and she is going to present on exotropia. So welcome, Dr. Aishwarya, and now you can share your slides.
Thank you, ma'am. Ma'am, should I start?
Start.
Yes, you can start.
Okay. Good evening, everybody. I'll be discussing about exotropias. So as you all know, exotropias, the word itself suggests that it is an ocular misalignment with the divergence of visual axis. Exodeviations are generally more common than exodeviations worldwide, but in studies done in Indian subcontinent, they show an almost equal distribution of exotropias as well as esotropias. We know that the angle kappa, which is the angle between the visual axis and the pupillary axis, is almost universally positive. But a higher positivity of more than 5 degrees can lead to an appearance of a pseudo-exotropia, as can be seen here. Exotropias can be comitant where the amount of exodeviation is similar in all the 9 gazes, or it can be incomitant where it is different, the comitant can further be subdivided into primary and secondary. Essentially, what we'll be discussing is the primary comitant exotropias. It is important to understand the nomenclature of exotropias, mainly heterophorias and heterotropias for distance as well as near. For the ones that are relevant today, I have marked in the box in orange. Essential infantile exotropias are large angle deviations which are early in onset around 6 months to 1 year of age and not associated with other causes like neurological diseases. In infancy, the most common form of squint is esotropias, and exotropias are rare. Thus, they should always be investigated for neurological abnormalities. Intermittent exotropias, or IDS, intermittent divergent squint, is an acquired exodeviation which tends to manifest when the patient is tired, unwell, or under the influence of drugs. It is the most common form of manifest exotropias and is seen more commonly in females as compared to males. Patient presents with the clinical features of headaches, eye strain, blurred vision, and diplophotophobia, that is, closes one eye to avoid diplopia in bright light where the fusional vergence is disrupted. It begins as a latent deviation which over time deteriorates into an intermittently manifest deviation. In initial stages, there is a facultative scotoma, which is the adaptation to corresponding non-corresponding retinal points in the 2 eyes to avoid the diplopia. The suppression is facultative in the initial stages, and which means that it is present when the exodeviation is manifest, and it goes away when the eyes are aligned. And thus, in the earlier stages, the patients can have normal stereopsis. The distance stereoacuity is one of the earliest indicator of the loss of fusional control in such patients, which can be measured by Frisbee-Davis distance test, distance Randott, and thus it can give an idea of patients who are further deteriorating into IDS. Calhoun gave us phases of progression of exodeviation from exophoria for distance to exotropia for distance to suppression scotoma for distance, and further final stage for the lack of binocularity, which essentially becomes an alternate divergent squint. It has been classified into 4 types and further classified by Burian and Kushner. This table tends to intimidate residents, but let us try to simplify into a more categorical concept. When the distance is equal to near or less than 10 prisms of difference between the two, it's a basic type. When the distance is more than near of more than 15 prisms, you patch the eye. And after patching, if it becomes equal, it is a tenacious proximal fusional convergence. If it still remains more, you put a +3 diopter. If then it becomes normal, that means the patient had a high AC by A ratio to begin with. And if it still doesn't become normal, that means it's a true divergence axis. The same can be applied as a corollary when the near is more than distance, that if you patch it and it becomes normal, that means tenacious distal fusion. If you put a -2 diopter and it becomes normal, that means there is an insufficiency of the fusional type of convergence. And if it does not become normal, that means there was an insufficiency of the accommodative type of convergence. Basically, a convergence insufficiency which causes an increased amount of exodeviation at near as compared to distance. The grading can be done by a Newcastle score, which have been revised for a clinical control for near and distance and for home control. The management includes counseling as for any disease, which includes non-surgical and surgical options. Non-surgical options include optical correction, where overcorrection of the myopia can trigger the accommodative convergence and help in decreasing it. Jampolsky, the photo of which who was on the first slide, has said for -3 diopter, was Kushner advises -2 diopters. Bayesian prisms can be given for optical correction. We can give convergence exercises in the form of pencil push-up tests or synopter for exercises for clinic-based tests. Anti-suppression therapy in the form of bar reading, video games can be given. Indications for surgery include symptomatic IDS, exotropia more than 50 waking hours, increase in the Calhoun stage, or decrease in the stereoacuity. The surgical considerations include when to operate, which depends on the child's neurodevelopmental status and the frequency of the deviation. Basically, you weaken the LR and you strengthen the MR, and depending on the presence of A or V pattern, you can weaken the obliques. The desired outcomes mainly include the stereopsis, less so binocularity, and accepted outcome as orthotropia. Thank you.
Very well presented, Dr. Aishwarya. Now I would like to request Dr. Digvijay sir to proceed with the questions.
Yes, Aishwarya, I think very well presented and very well summed up in the time, just in the right amount of time. Okay, 2 quick questions for you. I mean, they're all both linked. What is lateral incomitance Why is that important basically? And why are we operating exotropias later as compared to esotropias?
So there could be an abduction limitation, which can cause the lateral incompetence, which is surgically important as it helps in deciding whether to you do an FDT and you decide to change the management of surgery with going with bilateral LR recession or RNR. And the next question.
Okay, and why are we operating exotropias later?
Yes, sir, esotropias will have a higher frequency of amblyopia, and which is why we tend to operate them earlier. Exotropias have a tendency to fuse because of the fusional as well as the accommodative conversions, so we can go wait for a later amount of time for exotropias.
All right, thank you. But lateral incompetence is slightly different in concomitant exotropias. It's not necessarily, so it's just a lower amount of exo in the side gazes, which means
compared to primary gaze.
Yes, which means you want to do lesser amount of lateral rectus recession, but it is not linked to restriction. So FTT would not help in this case.
Right, sir.
I request Dr. Anu ma'am now to proceed with the questions.
Wonderful presentation, Aishwarya, and very nicely elaborated all the various concepts. You talked about the angle kappa in your presentation. So can you discuss various visual angles and their importance, and also how to measure this angle kappa?
And the visual axis and the pupillary axis is the angle kappa. The optical axis and the optical axis and the pupillary axis is angle alpha. Angle kappa is important for squint patients and also for and the angle alpha is important in cases with multifocal IOLs, because you might there might be a difference between the center of the bag and the center of the cornea. And angle kappa is also important in cases where you are doing a LASIK, because again, the center of the cornea can be different from the center of the pupillary axis.
And how do you measure this?
Ma'am, I'm not sure.
All right, thank you.
Thank you, ma'am.
Thank you, judges. Thank you, Dr. Aishwarya. Moving on to the next participant.
Kindly share the slide.
I'm sharing. Yeah. So, Dr. Abdul, please introduce our next participant.
Now, next, we have our next panelist for presentation, Dr. Anu Harish. She's from Azizia Institute of Medical Science, Kollam, Kerala. She is presenting a topic on OCT and neuro-ophthalmology. Dr. Anu Harish, kindly share your slides and all the best. Make it full screen, please.
Yeah, please start.
You're muted. You're muted. Anu. Anu, you're muted.
Am I audible?
Yeah.
My topic is optical coherence tomography in neuro-ophthalmology, and I'll be mainly focusing on the applications of OCT in neuro-ophthalmology. In neuro-ophthalmology, we usually do an SD-OCT with EDI mode. So OCT in neuro-ophthalmology helps to take the picture of a reproducible picture of a structure of optic nerve head, the retinal nerve fiber layer health, and the ganglion cell complex health. So the importance is that it aids in diagnosis, monitoring, and provide prognostic information in neurodegenerative condition by capturing and quantifying the axonal loss and the neuronal damage. There are two protocols which we use. One is the RNFL protocol and one is the macular GCL protocol. In RNFL protocol, we use the peripapillary RNFL analysis and the optic nerve head parameters. In macular GCL protocol, we see the thickness of the macular GCL and the inner plexiform layer. So first, let me go to the multiple sclerosis optic neuritis. In this picture, we can see that in the symptomatic eye, in acute stage, we see a thickening of the optic disc due to the underlying edema. But in asymptomatic eye also, we are able to see thinning. So here, the OCT helps in detecting the RNFL loss even in the asymptomatic eye of patients with unilateral optic neuritis in multiple sclerosis. Thus, it detects the subclinical disease activity and provide evidence of dissemination in time time and space in patients with suspected multiple sclerosis. Here we can see that thickening of both RNFL and GCL is present in the acute stage, but by second week, the RNFL thickening is still there, but the GCL thinning is noticed. This is a biomarker of early structural loss. The RNFL thinning in secondary progressive multiple sclerosis is more than that of the other multiple sclerosis. The macular GCIPL thickness correlates better with the visual function and MRI. So OCT provide no evidence of disease activity in patients with stable RNFL thickness over a period of time. It also predicts the visual recovery. So progressive RNFL thinning is observed in patients with multiple sclerosis, even in the unaffected eye. In NMOSD spectrum of diseases, the RNFL thinning is episode related and the unaffected eyes do not have thinning, unlike in multiple sclerosis. There is severe thinning of both RNFL and macular GCIPL, so this has a very poor prognosis. So in MS optic neuritis, there is a preferential involvement of the temporal quadrant, while in NMOSD, it is the superior and the inferior quadrant. Microcystic macular edema is small hyporeflective spaces in the inner nuclear layer in the parafoveal region, and it is associated with disease activity in MS, and it signifies worse prognosis. In anterior ischemic optic neuritis, GCL thinning is seen as early as 2.2 days, and the pattern of GCL loss indicate the degree and pattern of visual field loss as seen in this picture. In non-arteriotic AION, the OCT identified different pattern of RNFL involvement specific to different classes of visual field defects. The GCIPL loss pattern is often altitudinal here. The presence of subfoveal fluid in acute stages in NAION is present, the resolution of which can give some visual recovery. In pituitary adenoma, it mostly has a prognostic, it is used as a prognostic tool. The normal RNFL thickness shows a greater potential for visual function improvement after an adenoma removal. But if the RNFL thickness is less than 5th percentile, there will be an incomplete recovery. The RNFL does not correlate with the visual field, but a hemianopia on perimetry can present as a hemimacular atrophy on macular GCIPL thickness map. In papilledema, it helps to serially monitor the degree of optic disc swelling in consecutive visit, and it shows as a response to treatment. If there is a reduction of RNFL with preserved GCIPL, there is the treatment success, but if there is a reduction of both, it signifies worsening of optic neuropathy and treatment failure. In optic nerve head drusen, it helps in distinguishing papilledema from pseudopapilledema due to buried deep optic nerve head drusens. In papilledema, there is a lacy V pattern, but in optic nerve head drusen, there is a lumpy, bumpy internal optic nerve contour and rapid decline in the subretinal hyporeflective space thickness. In Leber's optic neuropathy, the earliest changes are in temporal and the inferior quadrants, but later there is involvement of superior and nasal quadrant, which signifies dynamic evolution of acute stage. We can see thinning of RNFL in Alzheimer's disease and also Parkinson's disease. Here we can see a foveal pit is thinner and broader in Parkinson's disease. Coming to OCT angiography, so peripapillary radial capillary network is seen through OCT angiography, and reduced perfusion in this layer is seen in optic neuritis, Leber's hereditary optic neuropathy, Alzheimer's disease, and ischemic optic neuropathy. And absent foveal perfusion signifies AION. Thank you.
Thank you, Dr. Anu Harish. That was nice presentation. Now I would like to ask Dr. Digvijay sir to proceed with his questions for the panelists.
Well presented, Anu. So Anu, can you tell me something about how will we differentiate papilledema from optic neuritis on the OCT? Something that was described by Dr. Cooper-Smith and his team. Do you know?
In optic neuritis, one thing is the other eye might show a thinning in case of optic neuritis, and in papilledema in early stages there won't be a thinning of the GCL layer.
Okay, that comes later, but basically there's something there's an RP Brooks membrane angle that was described. So if that is positive towards the vitreous by Dr. Cooper-Smith and his team, then that is more likely to be in papilledema than in optic neuritis or any other ischemic form of neuropathy.
Okay, sir.
Dr. Vivek sir, can you proceed with the question for the panelists?
Right. Well presented, Anu. Again, a very broad topic for 5 minutes. But if I can ask you, are you aware of something called as a test-retest variability in measuring things like RNFL and GCC? And what is the importance of knowing what is the test-retest variability?
I'm not aware, sir. I've heard it, but I cannot recollect it right now.
All right. So this is something you would want to possibly go back and see for machines which have tissue measurements, or even for, say, your applanation tonometer or your tonometers, handheld tonometers. There is always a range known as a test-retest variability, within which you may not take the difference as significant. So this can be important, especially when you talk of subclinical measurements, right? You do not have a patient having real clinical findings in front of you, but your test is throwing up some value, which is possibly being pathologic. Then you repeat the test again and see what is the variation. So for every machine, for every measurement, there is a test-retest variability either provided by the company itself, or if you go back and check literature, you will see that a lot of researchers actually check for these measurements. So all of these have their own test-retest variabilities, which you should have a consideration upon whenever you are using these measurements in your clinical practice.
Okay, sir. Thank you.
Well presented. Thank you.
Thank you, sir.
Thank you so much, Dr. Anu. Meanwhile, the judges can score. We'll move on to the next participant.
Yes, ma'am. Slide, please, ma'am.
Just 1 second.
Yeah.
One second. Hold on, it's not moving. Stop. Let me just share again. It's not moving.
Yeah. Can I just proceed?
Just pardon me. No, just 1 minute. Just 1 minute. Just 1 minute.
I can do it from my end if you don't.
Yeah, please. Yes.
Okay, our fourth finalist for tonight is Dr. Lipi Mittal. She is from ASGI Hospital, Jodhpur, Rajasthan. She is presenting a topic posterior polar cataract. I welcome Dr. Lipi Mittal and all the best. Kindly share your slide.
Thank you, sir. Is it visible?
Yeah, make it full screen, please.
Yes, sir.
Please
Start, please.
proceed.
Good evening, everyone. I will be discussing posterior polar cataract tonight. Posterior polar cataract is a round, discoid, opaque mass which is located on the central posterior lenticonus region, usually bilateral, without any gender predilection. It occurs as a sporadic occurrence, but autosomal dominant inheritance can also be seen. Clinical features depend on the central opacity and the vacuole-like changes in the vicinity of the central opacity that can range from glare, intolerance to light, reduced contrast sensitivity, and decreased visual acuity. There are a number of classifications for PPC. One of them is Dr. Daljit Singh's classification, in which type 1 is associated with posterior subcapsular cataract. Type 2 is well-defined round opacity with an onion peel-like appearance. Type 3 is well-defined round opacity with dense white spots at the edges. And type 4 is a combination of above and nuclear sclerosis. Preoperative counseling of the patient is of utmost importance, where we should counsel the patient about the nature of the posterior polar cataract, the pre-existing posterior capsular defect, which may lead to a complicated surgery and hence relatively long duration of surgery, chances of delayed visual recovery, chances of nucleus drop, and need for secondary intervention, which may include need for secondary IOL implantation, need for posterior segment intervention, and Nd:YAG capsulotomy for residual opacity. We should construct a continuous curvilinear capsular axis of adequate size, avoid anterior chamber fluctuation, use high molecular weight viscoelastic, and low parameter phacoemulsification is used, wherein low vacuum, low aspiration rate, low inflow parameters, and slow motion phaco is done. Hydrodissection should be avoided. Hydrodelineation is imperative. One technique is inside-out delineation technique, which has been described by Dr. Vasavada, as we can see in picture A. Picture B depicts golden ring formation, which is an indicator of successful delineation. Rotation of nucleus should be avoided. This is a surgical video in which there is construction of the continuous curvilinear capsulorhexis, followed by gentle hydrodelineation, in which golden ring formation is a sign of successful hydrodelineation. Coming to the nucleotomy techniques, phacoaspiration is done in softer cataracts. For harder cataracts, phaco-chop technique is used. Lee et al. Describe one of the technique, which is lambda technique. As we can see in the picture, nucleus is sculpted in the form of lambda or V and cracked along one of the sculpted arms. For epinucleus and cortical removal, there is one reverse bloom technique in which after the nucleus is emulsified, the epinuclear plate and the cortical material are peeled off from outside to inside, just resembling the reverse blooming of the flower. Another technique is removal by viscodissection, in which the viscoelastic substance is injected in between the cortex and the capsule, and then the epinuclear material is peeled off. Sometimes after removing posterior polar opacity, the impression of the onion ring is seen, which gives an appearance of a hole. But since the posterior capsule is intact, it is termed as pseudo-hole site. Dr. Vajpayee et al. Describe layer by layer technique for epinuclear plate removal in cases of pre-existing posterior capsular breach. Care should be taken to leave the central area intact. In cases of posterior capsular rupture without vitreous prolapse, viscoelastic material should be injected before withdrawal of the handpiece. IOL implantation will depend on the size of the PCR. If it is small, IOL can be put in the back. If it is large, we should place it in the sulcus, and preferably multi-piece IOL with or without optic capture should be used. In presence of vitreous prolapse, anterior vitrectomy should be done. In cortical and nucleus draw, we should call for vitreoretinal intervention. Pearls to remember in PPC: construct an adequate size capsulorhexis, avoid cortical cleaning hydrodissection, gentle hydrodelineation is recommended. We should maintain a stable chamber. Low phacoemulsification parameter should be used. Gentle nucleus handling is recommended, and we should tackle the central epinuclear plate in the last part of the cortical cleanup. Thank you.
Very well illustrative presentation, Dr. Vivek. Now I would like to ask Dr. Vivek sir to proceed with the questions for the panelists.
Thank you. Well presented, Lippy, and I think appropriate number of slides for the amount of time that you had. I'll ask you a question from the point of view of imaging. So we usually pick up posterior polar cataracts on slit lamp examination. Now, is there anything described with respect to imaging which can help you predict whether you will get a dehiscence of the posterior capsule due to the posterior polar cataract on table?
Yes, sir. There are various imaging modalities. One of them is anterior segment OCT. Other is ultra biomicroscopy. Then shame plug imaging has also been described to assess the preoperative breach in the posterior capsule.
Right. So can you quickly elaborate as to what observation in any of these methodologies lead to a prediction of the fact that you are going to get a posterior capsular dehiscence on table?
So, sir, normally if we talk about anterior segment OCT, normally if we trace the posterior, the lining of the posterior capsule, it is intact or it is continuous. If there is loss of contour or loss of tracing of the posterior capsule, that detects breach in the posterior capsule.
All right. Thank you.
Dr. Anu ma'am, can you proceed with your part of questions?
Well presented, Lippy. Wonderful presentation and surgical videos. I would like to ask you practical questions. So I think it's come up on the chat box also. If you have polar in one eye and grade 4 nuclear sclerosis in the other eye, okay, so you can't see the PC, but grade 4 nuclear sclerosis in the other eye, what will be the choice of surgery and why? And also, what modifications would you do in the surgery?
So it depends on if I am doing phacoemulsification, then I should keep in mind that low phacoemulsification parameters should be used. Then I should avoid, I will avoid hydrodissection and hydrodelineation.
Can I interrupt you once here?
Yes, ma'am.
Yeah, so these are all the pointers that you've already described in your slide, which are very apt for any polar. So I
Yes,
would know, what would you prefer? You said if I do FICO, I would do this. What is your choice of surgery and any other modifications, and why?
Ma'am, if it is advanced nuclear sclerosis with PPC, I would like to go with SICS.
Why so?
Because, ma'am, more stability of the anterior chamber, phacoemulsification. If I do phacoemulsification in these cases, I do not know the status of the posterior capsule preoperatively. So I would like to go ahead with SICS in this case.
All right, thank you.
Judges are scoring. I would like to announce to all the audience back there, please be seated. We have an audience polls.
Ankita, your voice is feeble.
Okay. Am I audible
No,
now?
it's
Yes, ma'am. Yes.
Yeah.
A little
So
bit low.
this is just a message to all the audience back there. Please be seated. We have the audience poll, so do vote for your favorite contestant. May the best win. So please be there. So we'll move to the next one. Yeah. Dr. Rakhi, please go ahead.
Yeah, our next finalist for the day is Dr. Reshma Padmaram. She is currently working at Dr. Agarwal's Eye Hospital, Kerala, and she'll be presenting the topic of anti-VEGFs in ophthalmology. Dr. Reshma, now you can share your screen.
Thank you, ma'am, for the kind introduction. I'm trying to share my screen. Are my slides visible?
No.
No, not yet.
Try to share again.
Now?
No, only you are visible.
Unshare and share again.
Dr. Ankita, we have a question from the audience.
Yeah.
Dr. US Tiwari asks, if any spoke of cortical opacity is present, does that mean the risk of CPCD is less?
Dr. Lippy, I think this question goes to you. Would you like to answer? In the meanwhile, Reshma is trying to get her slides. Dr. US Tiwari, sir, he is an HOD at Indore. Welcome, sir. It's an honor to have you here, sir. Dr. Lippy, are you there? I think Dr. Anu ma'am can take over.
Sorry to interrupt. Is my screen visible now?
No, Reshma.
No.
Not.
Should we?
We'll just try it again. Anu ma'am, you can take the question between.
Hi. So I personally feel when you have these cortical spokes, then it does indicate that the cataract is progressive rather than a stationary element. So we would expect some amount of thinning in the posterior capsule, and I feel the risk might be more compared to a stationary posterior polar cataract, which does not have these cortical spokes. What is your experience, Dr. Vivek?
Yeah, as a retina surgeon, when I do cataracts, I don't think now I'm not assessing that much with respect to posterior polar cataract and its risk. But the question that I asked to the presenter was something that I do use in practice if I encounter a posterior polar ASOCT showing a dehiscence or discontinuity in the posterior capsule. Gives you a good idea of the likelihood that you are going to have of the capsule opening up on table. Maybe as a retina surgeon, we have that luxury that in case something really happens, we are possibly able to manage it there and then. So maybe we may not be looking at the finer points like a cataract surgeon may be looking at.
I also feel that even if you have a harder cataract, then other than ASOCT, which might not give a clear image, you can go in for a UVM at any time. And if you're lucky, like being at RPC, you can take the help of intraop OCTs that could have been mentioned. Also, in the meantime, while the presenter loads the slides, cataracts, I personally feel there's no one answer, for SICS versus phaco. The surgeon, it is based on his or her confidence. So if he's more proliferant or proficient in phaco, he should go ahead with that. Or if he's more proficient in SICS, it should be that, rather than, trying something new or trying something that you're not comfortable with. And anytime you have a harder cataract with no visibility of posterior capsule, but some amount of element of PPC in the other eye, always watch out for that. Take all the precautions, because it is very highly likely that you have a PPC in this eye as well.
Dr. Ankita, you're muted.
Yeah. Thank you so much, ma'am. Dr. Reshma, can you just try again? It's still.
It's showing your screen sharing, ma'am, here for me.
Yeah, please go ahead. Sorry.
Good evening, everyone. So let's see anti-VEGF agents in ophthalmology. And about VEGF, it is a short form for vascular endothelial growth factor.
I'm not exactly seeing the slides. I'm seeing the downloads folder.
Yeah, select the right window. Reshma, when you go to the slide share, select the window which is showing the presentation.
It's a full screen for me here, actually.
So escape it, close that once.
Okay, I'll stop share and then I'll try again.
Now when you share, select the...
share the entire screen, basically.
What about now?
Yes.
Yeah.
Yeah, fine. Yes. Please go.
So as we all know, VEGF is the short form for vascular endothelial growth factor, and it has a normal role in vasculogenesis, and pathological part is called angiogenesis. History dates back to 1983, where it was identified as VPF, and researchers went on and on. And in 2004, we got our first agent Avastin as FDA approved. And the family has different types from A to D and the PIGF, each with a specific function. There are multiple isoforms for VEGF-A itself. And the initiating stimuli in eye is hypoxia, which causes the RPE to release pathological VEGF-A. And whenever there is an imbalance between the pro and the anti-angiogenic factors, the cascade sets in. These vessels are not like the parent vessel. They are leaky, friable, they have more propensity for hemorrhages, and they cause tractions, and they grow into the vitreous, and they cause a lot of complications. So this is our army to fight against this VEGF and neovascularization. So if we see in 2004 to 2013, we have a dramatic evolution in these molecules. The route to the most common one is intravitreal. And we have pagatinib sodium, which is selective for 165 isoform, and it's the first FDA approved anti-VEGF agent for eye in 2004. Just because other beautiful agents came in, this guy was kicked out. And we have other agents like Lucentis, ranibizumab, Avastin, Eylea, aflibercept, and brolucizumab. So these molecules are different in their structure and specificities. If you see aflibercept, it is a fusion protein, and it is also active against VEGF-B and PIGF. And they are very different pharmacologically as well. Brolucizumab is a single chain antibody fragment with a clinical dose of 6 milligram, and is also having effective penetration in the choroid. And brolucizumab is superior over aflibercept at 96 weeks, according to Hawk and Harrier. This guy was notorious for intraocular inflammation and occlusive events. Biosimilars may have minor differences in clinically inactive components. And bevacizumab, we have used Cybeb in India a lot, and it has DGCI approval. Trazumab also has DGCI approval. SB11 is approved last year, 2 years back, to treat macular degeneration by FDA. We have many biosimilars of aflibercept still in research. Ranitidine is by Reliance, and it is recommended for a once-in-a-month dosage. We use this commonly for DME, CNV, vein occlusions, PCV, RFP, and less commonly for macroaneurysm-related macular edema, VPT, uveitic CME Coats disease, and NVG. In CNV, it is a major achievement because all types of CNV anti-VEGFs work really well. And as a surgical adjunct, we use in vitrectomies. In anterior segment, we use it for tertium surgeries, and dramatically this reduces corneal neovascularization also, and major systemic events in past 3 months are relative contraindications. We also have to keep the chances of endophthalmitis in mind. And ranibizumab and bevacizumab had some non-ocular hemorrhagic events reported as well. So I would like to tell a bit about the long-acting anti-VEGF agents. We have the ranibizumab food delivery system, and which is a permanent refillable intraocular implant. And abicipar was tried but rejected because of safety concerns. This is a very promising molecule which is FDA approved recently for DME and NAMD, and it is bispecific. It also acts against angiotensin II, and it has claimed to have a duration of effectiveness for 4 months. And the ones are oral route PTK 787 has been tried, and siRNAs are also in research. To summarize, anti-VEGF agents are effective with no difference in CNV and DME. Laser treatment still has a role, and we should know something here about tachyphylaxis. This is receptor fatigue, and in these cases, we'll be switching to another molecule. Treatment should be individualistic, and we should follow evidence-based medicine, and it has a good potential in future also. So thank you for your patient listening.
Well done, Dr. Reshma. It was well presented. Now, I would like to ask Dr. Vivek to go towards the questions chair.
Nice presentation, Reshma, and a nice pace of your entire diction through the presentation. When we have all these new biosimilars that are coming into the market, in your opinion, how do you place the usage of Avastin as against these biosimilars? Would you have a preference in your practice over any specific biosimilar over Avastin or vice versa?
So Avastin still has an off-label use only in ophthalmology. So I would not prefer Avastin over any other biosimilar.
Okay, so do you think there is a cost implication even now with respect to Avastin and a biosimilar, or that part is sort of neutralized out?
That is sort of neutralized, sir. Most of the biosimilars now are available at a better, lower cost.
Okay, and quickly, as compared to Avastin, in a biosimilar, would there be any specific side effects that you would look out for if you use them?
Mostly intraocular inflammations.
Okay, so how would you differentiate that from a possible post-injection infection?
Maybe more of a occlusive tendency also.
Okay, all right. Okay, thank you.
Thank you.
Next
presentation, Dr. Reshma.
Thank you, ma'am.
And quite a holistic involvement of all the newer drugs as well as the previous drugs in a brief time. You talked about Avastin and its FDA approval. So can you describe what is FDA approval for Avastin, for which cancer has it been approved?
It's mainly for GI cancers, ma'am, colorectal cancers.
It was first approved for colorectal in 2004, like you described, but any other cancers that it's used for? Since you mentioned it's off-label for eye.
I'm not really sure.
And I mean, another thing that I was noting in your slides was, although everything was mentioned, you could have mentioned about the dosing and the frequency that would have made them even better than they already were. Can you describe the frequency schedules for various anti-VEGFs and the regimes? Whether you prefer monthly injections or 3 monthly or need basis? What is your go-to regime?
The injection part, I will ask all the patients to come up for a 4-weekly scan, and then only I will decide, because sometimes when we give in retinal venous occlusions and all, the first injection itself, they will go to somewhere around 250, 200 range. Then I would be little hesitant to give the loading dose also.
All right, thank you.
Thank you, judges. Moving on to the next presentation. Dr. Raki?
Yeah. So our last finalist for the day is Dr. Supriya Mushrif. She's from Index Medical College, Indore, and she'll be presenting on the topic smartphone in ophthalmology. Dr. Supriya, you can now share your screen.
Dr. Supriya, please unmute yourself. Unmute yourself, please. You're not audible. Dr. Supriya, please unmute yourself. Yeah.
Yeah, it's from your side, sir, ma'am. It was from your side.
Sure,
It
sure,
was
sure.
coming.
Yes,
Then,
sir.
yeah, yeah.
I'll share.
So,
I'll share. Yeah.
so first of all, before starting, I just want to say my laptop again it's not working, and as can you think I have to start my slide smartphone ophthalmology from my smartphone only? That is a paradox. Hello, can you all hear me?
Yeah, but your voice is breaking. Hello?
Yeah. Can you hear me now?
Yeah. You're audible.
Hello.
Maybe Dr. Supriya can
Please give me a minute. Yeah, please. Please. Can you hello? Can you all hear me?
Yes, we can.
Hello.
Yeah, you're audible. You're audible.
So please share my slides. Can you share?
Yeah.
Slide because I have to
I'll do that.
start from my smartphone.
I think, Dr. Supriya, your network bandwidth is low. Maybe you could switch off your video and it'll help connect better.
Sure. Is it okay? Is it okay?
I think we can hear you better right now.
Yeah.
Can you hear me now?
Yes, we can hear you. I'm sharing your PowerPoint. Just 1 second. Yeah. Dr. Supriya, you can see your PowerPoint, right?
Hello.
Yeah. Can you see your PowerPoint?
No.
Dr. Nilesh, can you see the PowerPoint?
Yeah,
Yes.
I can see.
Visible here.
Dr.
Should I start? Hello.
Yeah. Please go ahead.
So smartphone in ophthalmology by Dr. Supriya Mushrif. And to start with, why I'm here to start tell you everyone by smartphone. Because nowadays we are using a smartphone in our daily routine life. Not even for our food purpose, for job purpose, for anything, we are using smartphone. Because it is an increasingly considered handheld computers and at advanced computing abilities, we are using in everything. Now, please next slide, ma'am. Yeah, next slide. So because of a tremendous application we are using in medical science, then why not in ophthalmology? Next slide, please. So I just wanted to know, and I tell everyone this question always used to come in mind, why ophthalmologists should be aware of smartphone. Because nowadays little is discussed about this use of smartphone in ophthalmology. As eye care professionals, those who most of the people do not know about it and who knows about it is very skeptical to use the smartphone because it is not validated, it's not official, no researches have been done on it. Next slide, please. So the question came in my mind and I decided to start research work on it. And because of this, I get to know a lot of things. An American Society of Cataract Refractive Surgery survey in 2010, 83% of members use smartphones in professional tasks. So this gave me a thing and I decided to do a classification. Next slide, please. So I decided to classify the use of a smartphone on the basis of its camera and application use. And the various smartphone apps is again classified by
Dr. Supriya, I think your network is poor.
Next slide, please.
Yeah.
Use of camera. Next slide, please. Hello. So on the basis of its camera using, we can use smartphone instead of fundus camera for anterior segment photography and posterior segment photography for teleophthalmology and teleconsultation. Next slide, please. And also for a smartphone app, we can use for our purpose, education purpose, patient education purpose, and also for our branding and marketing. Next slide, please. And now this is a special picture which is close to my heart, and the big credit goes from our Index Medical College and myself. I have done this fundus imaging without using indirect ophthalmoscopy, just by smartphone and 20-degree condensing lens. Here we can see a macular hole of a retina. And in this way, we can use smartphone as a jugaad technology instead of fundus camera. Next slide, please. When I get to know in my research, there are various other jugaads in this. There is do-it-yourself RetCam. Next slide, please. There is Make in India Retina Cam for pediatric patient screening. There is Fresh to Treasure RetCam. Next slide, please. And Make in India RetCam. Next slide, please. Fresh to Treasure, where we can convert our smartphone in a fundus camera by a bottle, a fresh bottle. And this is a 3D printed smartphone adapter. Next slide, please. For video recording in our surgery. Next slide, please. Also, there are certain dedicated apps for fundus photography. Next slide, please. So I have concluded we can use our smartphone for knowledge. In this, we can see we 3 people are getting benefited by one smartphone. Patient, examiner, and student is getting to know about the disease the patient is having. Next slide, please. Now, this is smartphone-based gonioscopy, where only smartphone and gonioscope is helped in evaluation and also recording the pictures of anterior angles. Next slide, please. Now, there are various apps also. Nobody knows, but there are 342 ophthalmological applications for eye caregivers, but nobody knows about it. And 121 are for ocular surgery only. Next slide, please. Now, apps are again classified on the basis of which are helpful for ophthalmologists and patients. Next slide, please. We ophthalmologists, as we all know, what we are doing now. I am doing this webinar on my smartphone. We are doing this everything the e-journal, e-book. We can easily and quickly get access to our e-journals. Teleophthalmology, teleconsultation. This smartphone in COVID time will help all ophthalmologists and also all medical professionals. And for patient assessment, hello. Next slide, please. So, patient education tools, ophthalmologic education tools. Next slide, please. For webinars, for websites. Next slide, please. For podcasts, for ebooks. Next slide, please. Please do. Next slide. Yeah, next slide. For calculating, for branding of ophthalmologists. Yes, please skip it. And for eye handbook, where we can refer our ICD coding and various differential diagnosis. Next slide, please. For MRD record keeping. Next slide, please. Language translator app when the patient do not know English or Hindi and we do not know their language. Next slide, please. Last slide, I would like to come in summary. There are various patient educational tools also. It can help in patient education for patient awareness. Last slide, please come on summary. There are various patient assessment apps. Innovative. There are various quantitative and qualitative analysis summary. Acquiring the continuously updated information quickly and accurately. Apps in ophthalmology is helpful for us. And last slide, please. Yes, my take-home message is thus: we as an ophthalmologist and doctors are responsible, have responsibility to guide development of validated apps in collaboration with app developers to acquire knowledge regarding validated apps, to educate patients and students regarding benefit of a smartphone and its validated apps in their routine, and to promote validated apps for their future use. Next slide, please. So in the end, it's time to upgrade. We as a smartphone and a smart ophthalmologist, we should not know ophthalmology, but we should also know some computer science, artificial intelligence, and smartphone apps. Thank you.
Well presented, Dr. Supriya.
Yeah, it was. I could have presented much better, but my laptop and my network has an issue. What can I do?
You have well used your jugaad and everything.
Yeah, and I have in my smartphone and ophthalmology, I have presented it with a smartphone only. So I have proved my thing. Yeah. I just can.
Okay, now I would like to request Dr. Digvijay sir to ask questions to Dr. Supriya.
So good, Dr. Supriya. I think I would have been happy if you had said that I presented it better on my smartphone than I would have presented it elsewhere. But a quick question. Can you name 4 or 5 apps in the smartphone that can be used for fundus imaging?
Not audible, Dr. Supriya, your voice is cracking.
Hello, can you hear me?
Yeah.
Yes.
Yeah, please.
Hello, can you hear me?
Yeah, now you are clear.
Yeah, there is Ullaman indirect app for fundus photography for iPhone itself, for fundus photography. And also Remedio are doing good thing for anterior segment imaging.
Yeah, there are many fundus apps. One is one, correct? Are there any other that you know of?
No, sir. In my research, I get to know 2 to 3, but right now I haven't brushed up. In my mind, it's Ullaman only. Yeah.
Okay.
Yeah.
So next, I would like to ask Dr. Anu ma'am to ask few questions to Supriya.
Hi, Dr. Supriya. Well, very informative slides, and you've covered a lot of apps. I would like to know what are any best 3 or 4 apps that you are personally using in your practice. Summarized a lot, and there's been a lot in your slides, but what are you personally using?
Yes. I am personally using, sometimes for first travel, I will use for camera. I'm using my smartphone camera. I know you're asking for apps, but for camera, I can use for fundus photography and for recording and also I'm using for my purpose, for my educational purpose, AAO, Medscape and IGO, all the apps are there, and I don't need any hard copies, anything to access any journal. So these are for my purpose. And there are various apps, I will not tell you the name. It's for the hospital where we can do our branding also. So it's for my personal use, and I am also a teacher. So for my students, I am like various apps for educational purpose are there, and I give them advice to use this AAO app and for knowledge purpose and everything.
All right, thank you.
Dr. Vivek, you can also ask the question.
Actually, I had a similar question, but I think Digvijay has already asked. I was going to ask about fundus imaging apps. But all in all, I think I'll just have a comment. Wonderful presentation. It's a little out of topic, but in sync with, I think, the way science is going to go forward. So from that point of view, a lot of nice things were summarized in the slide, in spite of the technical glitch. It's very easy for somebody who's presenting to sort of be just put off by the technical glitch. But I think she was just not put off. She took it in her stride and presented very well. So that's commendable.
Thank you, sir.
So with this, we come to an end with all the finalists. Thank you so much, judges. Thank you so much, all the participants. It was really a wonderful eye-opener and many points to learn and take back home for all of us also. I request all the judges to please finish up the scoring. In the meanwhile, we'll just open up the audience poll. Please do score for your best presentation, whomever you feel so, because that will be a game changer for the scoring. So we'll start the audience poll. Meanwhile, judges, please finish the scoring.
The audience poll will go on for 1 minute. So I'm launching now.
Yeah.
Can everyone see?
Yeah.
Yeah. All the best, everybody.
So till the poll is going on, I think we can ask our judges how they felt and what else we can do better in the future. We'll start with Dr. Digvijay, sir.
No, I think all the participants have made wonderful presentations. It's very difficult to finish these large topics in 5 minutes, and these are abridged versions, obviously, of the slides. I think for future one, probably we could consider giving them 1 minute more, and that will make a difference. But also, I think we can also clarify that I mean, as judges, I would like to say that we don't expect to see everything about every topic within that slide, right? But as Dr. Vivek had said, it's a kind of key messaging that has to go across out there. And we can have some, short videos or something else as well. You guys can incorporate animations and videos to better your audiovisual presentations.
Sure, sir. We'll do that. We'll make sure. Dr. Anu, ma'am.
I think it was a very well conducted session, and I have to say you've summed it up in quite a decent amount of time, because generally these webinars go on for quite a long time and gets really late. But most of the presenters take time, and you as the conductors also managed to do that very beautifully. A key message for all the presenters would be, just like Digvijay sir mentioned about take-home message. I think these are the slides they had already uploaded on for the YouTube, and that's what they were presenting. So not really a bridged version, but some of the presenters had included, objectives and take-home messages. So that can be done in all the slides, the first slide being an objective. So what are you trying to convey and what all you're going to cover up in those slides? And the take-home message or the summary, which finishes in 1 or maximum 2 slides. So that would be a take-home message for all the presenters, but very well presented, all of them, and beautiful use of audio-visual aids. So great work to all the team that was helping out figure this wonderful session.
Thank you so much, ma'am. Dr. Vivek, sir?
Yeah, I think the messages have been already summarized. But I was just wondering, are these topics allocated to them, or did they choose these topics on their own?
They choose on their own.
All right. Then maybe one suggestion would be that, whenever you get a time, it's like when you're invited for a talk, first question that you ask that person also is, what is going to be the length of my talk? And you then sort of start modifying your material with respect to that length, such that you have a flow of start, build up, and appropriate end. So what happened is, I could see that in a couple of presenters, you could see there was a wide difference. Some were rushing through their slides, some were having a very good pace, some were having material adequate enough that it would finish in time. For some, repeatedly, you all had to say that time is up, right? So I think this is just a learning experience for all of us. Often, when you go to national, international competitive sessions, if you exceed by even a couple of seconds, you may not be in contention for the prize, even if you're the best presenter. So it's very, very, very important to finish in time, and that ending should not be abrupt. That ending should be complete in the flow of start, build up, and end. So always look at what is going to be the time allocated for you to speak. And then possibly, if you have taken a very broad topic, like Digvijay mentioned, just nitpick 1 or 2 elements out of it, because your aim is not to teach everything in 5 minutes. If that was what it was, then I mean, OC team could have brought in 20 speakers and we would learn the entire ophthalmology in 1 evening. That is not going to happen. So bring in little material such that at the end of your slides, the audience has some retention and some very objective key points to take to the clinic. If you can modulate and put across points which are clinic applicable, there's nothing like it. You can also have objective theory points, but if you have something which is a finding, so and so finding in the squint, and this is the surgery that you're going to do, and a person can possibly note that, and next time he or she sees that in the clinic, can correlate. So I would say that might be the crux learning points out of this entire exercise. Thank you.
Nicely, Dr. The thing was, actually, we have started this use slides. It was for all the postgraduate students who are, preparing for the exam, so that they have all the notes in one place. Now, the thing was, when we are conducting it, when we are publishing all the 76 slides at a go. But when we are presenting it, we have requested them that either to take one part of the presentation so that they can finish it in one time, because obviously it's nearly impossible to complete such long topics in such a short time interval. So they have tried, but yeah, we'll hope for the next time best that they'll try it much better. and we will come up with a better ideas.
So it's a learning exercise. More and more you do this, more and more you know that the same topic you can either speak for 5 minutes, or the same thing you can even give a memorial lecture of 1 hour. So it all depends on, what is the time allocated and how you learn to modulate your material.
But I think at the same time, I would say from from the AOC side that Nidesh and all of you guys have done a great job with your slides to begin with. And I mean, Ankita, I think you've generated such great content for all the PGs, forever to come. This is absolutely an amazing exercise. I don't know if Dr. Vivek, you've had a chance to look at them, but I mean, Anu, I'm sure must have also seen them. But it's actually a fantastic, amount of content that there is. And I think all the postgraduates and fellows, whoever is attending here, seeing it live, you guys must go and have a look at these slides. Each of these slides teaches you a lot about how to make your presentations, and you can use this as a very good reading material for yourselves.
Yes, sir.
Absolutely.
I think another inspiring.
It's great material. Absolutely, I agree with you. It's a
Another
great compendium.
thing is that the winner of Your Slide 1 is now one of the organizers in Your Slides 2. So I think it just builds on with the team and gets more and more people involved in these activities. So it's really amazing to see. We have Ayushi here. She's been a student. She's been the winner of Your Slides, and now she's actively involved in this. So that's really inspirational.
Thank you, ma'am.
I would reiterate, great job by the entire team, especially also on the point that Dr. Anu mentioned, sticking to time. I think that is also a sine qua non of very good organization for the team who's organizing something, because otherwise this can just go on and on and on. There's no end to what every person wants to keep speaking with respect to comments and inputs. So it's extremely important to stick to time. And I think from that point of view too, you guys have done a great job.
Thank you so much, sir. And yeah, I'll agree with Dr. As said in the beginning that there were 70% of the topics which was asked in the DNB, and it was covered by our Your Slides. So it's actually very beneficial for all the postgraduate students. I wish it was there in our time also. I could have directly jotted down from there without making it.
It's wonderful because, there are a lot of topics that are not mentioned in books at one point of time. And you have to keep going through various articles or what is the recent updates and, searching multiple articles or making notes. So here you get everything at one go, along with visual demonstrations for better understanding. So really phenomenal.
Devakan sir? I think he left.
You guys have got all the audience poll as well.
Yeah.
So you're compiling the answers.
Yes, sir.
We're all eager to know.
We're almost done. We're just waiting for our final.
They're brilliant in having Google Forms and everything so that, it's a very quick work and the compilation is ready in no time.
So before I share the result with the team, I just want to know, it was like a clear-cut winner in the audience poll. So I'll share the result from the audience poll before everything else.
Dr. English, please share the top to us. Okay, so audience favorite, the posterior polar cataract. Congratulations. Let's see the overall marks. Just give me 2 minutes. We're almost done with the winners. Dr. Lipi, you can come forward. You are the audience. Actually, you can take over. Meanwhile, I'm just finishing it up.
Dr. Lipi, do you want to say anything? How was your experience?
Yeah, we should listen from the participant before we announce the results.
Yeah, sure.
Dr. Lipi, are you there?
Yes. I would like to thank you, the facility. Thank you, all the judges and all the audience who voted for me and who is present over here. Thank you.
Dr. Aditi, would you like to share your experience?
I really thank you, Your Slides, for giving me this chance to present something I have interest in. And Thank you, sir, for giving me some feedback so I can improve further in the future when I present. Thank you.
So, all set. We are ready. Anyone else has to say, or should we go ahead? So all the winners, the top 3 winners, in fact, the top 6 finalists, you all were great. The judges had a tough time and we had a tough time too to decide who is the winner and all those. The top 3 will be awarded at AIOSUC at Delhi, 8th to 9th of April, mostly at 8th of April, 1:30 p.m. We'll share the details further. So let's go ahead. And so here are the winners. So our second runner-up is Dr. Reshma. Congratulations. Our first runner-up is Dr. Aishwarya. Congratulations to you again. And the winner is Dr. Lipi Mittal. Congratulations to the top 3 winners.
Thank you so much.
Thank you.
Well done, all of you. Congratulations. I think your marks are all very, very close, I'm sure.
Thank you, sir.
So congratulations.
Congratulations to all the winners. Yeah, congratulations to all the winners and all the participants. I think making these slides is a task in itself, and submitting them and then being here to present, it just adds on to your skills and skill set, and even the further presentations. You start with online presentations and then gonna go ahead with the physical meetings, and it's a great learning for you all. Congratulations.
At least we can have a quick picture, no? With all of us.
Always remember, in a competition, some will win, but everybody will learn.
Yeah, that is true. 100% everybody learns. So I'll request everyone
requesting-
to please
Yeah,
click on their video.
everybody be on. We'll take a group photograph. The yo sign. Everybody, please.
Dr. Supriya, Dr. Anjali, Dr. Kaushik, sir, please come on. I can't see any more.
Yeah, done. Thank you.
Okay. Thank you so much. Thank you so much.
Thank you.